Thank you. Well, last and certainly not least is our final speaker of the day, Dr. Julie Rosenthal, who's the director of our amyloid clinic. She's going to speak to us about amyloid. Cardiac amyloid.
Wow, thank you all for staying today for the very last topic. First, I just want to thank our program directors for putting together this fantastic program and providing me the opportunity today to provide you an update on a topic I'm passionate about, specifically cardiac amyloidosis. With that, here are my disclosures, and let's get started. Hopefully we'll go through the background of amyloid today just to kind of give you an overview of what is amyloidosis. And by the end of this course, you'll be able to treat amyloidosis because we finally have therapies for our TTR patients as well as our primary amyloidosis patients. So with that, let's get started. I'd like you to take a look at this picture, and how many of you think person A has amyloid? B? C? D? It's kind of tricky, huh? Well, for those of you who chose B, you are correct. They have AL amyloidosis. But in this talk, you'll know that amyloidosis is a masquerader, so it really takes some good detective work to think about who has amyloid. Amyloidosis is a devastating systemic disorder secondary to protein misfolding. It's when these proteins misfold, they become fibrils and deposit into our tissue and cause havoc. In fact, there are more than 30 different pathogenic types of amyloidosis today. We're going to focus on two types that affect your patients, specifically cardiac patients. Those patients have transthyretin amyloid, otherwise known as ATTR, as well as light chain amyloidosis, or AL primary amyloidosis. By the end of today, you're going to know that amyloidosis is no longer a rare disease, it's just underdiagnosed. And my hope is that you'll figure out how to diagnose and detect these patients. There are a few cohorts of patients that I want you to raise your suspicion about. Those with heart failure and preserved ejection fraction, specifically those with increased interventricular septal thickness, your patients you're referring for TAVR, as well as patients with a history of bilateral carpal tunnel syndrome. We're also going to go through all the signs and symptoms of patients presenting with amyloid, and even if they don't have those signs and symptoms, if you're not sure why they have a cardiomyopathy, I'd like you to ask, could my patient have amyloid? So what are we talking about? This image on the left is a picture of our bone marrow. Bone marrow is responsible for making our plasma cells, which make immunoglobulins. Immunoglobulins are comprised of both heavy and light chains. It's when the light chain production goes awry that we have fibril formation and deposition into our heart. And these light chains cause two problems to the heart. One, through an infiltrative process, as you can see in this image, there is myocyte